Cameron Ninos. I'm primarily one of the pharmacists in hematology and stem cell clinics. Today, our lecture is going to be focusing on our oral chemotherapies for these areas. Maggie, Schenkat, my colleague, and I split this up. So my lecture portion is going to focus more on the myeloid agents, and then she's going to get more into the lymphoid agents. Diving right in, because we have a lot of material for you guys to cover. The objectives for whenever you guys finish or complete the lecture are to be able to review the indications and class of the various oral chemo agents. I always teach learners that class is really the basis and class mechanism of action so that you can really start to bucket these things. And that gives you those heuristics so that you can start thinking about what adverse effects are common to each class, what adverse effects are more unique to a specific agent within that class, and then moving that on to interactions, dosing, and administration pearls. So here's the overview for today, starting in the with CML agents, and then more into the myeloproliferative space, and then to AML and APML by the end. And then Maggie, like I said, will take over the second with the lymphoma, lymphoid active agents. Starting off with our BCR-ABL inhibitors, with our first gen imatinib, second gen dasatinib, nilotinib, bosutinib, third gen ponatinib, and then the new kid on the block, which is asciminib. And so this, I always find history a little instructive, and that it helps me remember these things a little better. So a little over 20 years ago now, we have Gleevec on the cover of Time magazine as the revolution in cancer care, that oral chemotherapy was going to be the future and that no one would be getting IVs anymore. Didn't quite pan out like we expected, but it still is an absolute game-changing drug, that it took something that was an orphan disease and permits people to now live a nearly normal lifespan. And so with our BCR-ABL inhibitors, that's a fusion protein resulting from a chromosomal 922 translocation, otherwise known as the Philadelphia chromosome. This leads to the tyrosine kinase to be constitutively active, resulting in uncontrolled cell growth. This is most commonly associated with CML, but also consistently seen in some ALL subtypes, and then it can be seen in other malignancies as well. And so I love tables to try to summarize big chunks of information. And so here's the first one for the day. You can see the various generations of the agents, which I think is really helpful, especially for this class of drugs, because there are some commonalities between the second gen agents. But just looking at that dosing to start, the one thing I like to call out is that nilotinib is our only one that's twice a day, which can just present some some challenges if patients might have adherence difficulties. The next thing I like to call out, generally with chemotherapy, everything is hepatically metabolized and usually via 3A4, and then renal adjustments are kind of here and there. The imatinib, that's our one exception that does require renal adjustment. The rest of the agents, including imatinib, do follow that standard hepatic metabolism, 3A4 substrates. So from an interaction standpoint, imatinib and nilotinib are both inhibitors. So if you have a patient who's on like tacrolimus post renal transplant, which we've had a few, those are people who we want to think about modifying. They're monitoring that tacrolimus level. And then other patients who are on 3A4 strong inhibitors or inducers end up actually being the biggest issues. The most common circumstance I've run into that with are patients being treated for epilepsy on things like carbamazepine or phenytoin. Those are much more challenging ones that we normally need to pair up with neurology clinic. And then food and how these medications are taken is important. You can see most of them, imatinib, dasatinib, bosutinib, are with food really for tolerability reasons. Nilotinib, once again, gets that call out, and that not only is it a twice a day medication, but it also has to be on an empty stomach for consistent absorption purposes. And in my experience, empty stomach is much more difficult than with food for patients, just because people are used to taking their medication. So once again, if you're choosing between agents for a patient who might have adherence challenges. Nilotinib might not be your preferred. And then the acid interactions are extremely important here as well. And this is where that second gen grouping is also helpful for us, in that all second gen agents have that acid interaction. Depending on the specific agent, sometimes the prescribing information may say that some acid suppression is okay versus other. So like nilotinib, it says you can space it by 2 and 10 hours from famotidine, compared with dasatinib that famotidine is contraindicated with. So there's some differences between them. But for this, I do like to emphasize that I think less is better across the board. So if a patient doesn't have a really good indication to be on it, we should be discontinuing these, because we know that it's probably not a stepwise curve. I think it's really continuous, that the more acid suppression these patients get, the less TKI they're ultimately going to absorb, and potentially minimizing our CML effect. I also had an interesting circumstance recently where a patient had to be on a PPI, and so we were trying to get creative. And the one recommendation that was given was to try to drink a can of Coke with each TKI from other centers. I don't think that's something I would routinely recommend, but I think it just shows that if you do have patients who need to be on these drugs, we can kind of put our heads together with other experts around the country and try to figure something out. Thankfully, that patient didn't end up having to resort to the can of Coke, but I still have that back in the back of my pocket going forward if we need it. Then moving on to our side effects for these agents, there are some class toxicities, bone marrow suppression, not surprisingly, with a lot of our chemo agents. And then rash can occur as well. And then since there's no magic bullet, these drugs often have off-target effects. Each medication can have unique effects as well. And so fluid retention is something that you see in most of these agents. However, it tends to manifest in different ways. So imatinib, the big fluid aspect I think of is periorbital edema. So watching out for any like vision changes as being a big red flag and counseling point for patients. Nausea is that imatinib does seem to have the most GI toxicity from what I've seen, even though it can definitely occur with other agents as well. And then musculoskeletal or joint pain, I do commonly think. Dasatinib, we also see that fluid retention. However, I think of it more in the pleural or pericardial space. And then you also can see pulmonary arterial hypertension as well as platelet inhibition. And I also think of dasatinib as being the most thrombocytopenic of these agents. So like we've had a couple patients who have forgotten to have their dasatinib dose reduced for their strong 3A4 inhibitor whenever they're on an antifungal. And the first thing you see on them is their platelets just immediately drop to like less than 20. So it is a potent platelet inhibitor. Moving on to nilotinib, which I always associate with kind of cardiac toxicity. And that's because it has strong QTC interval prolongation where we should be getting EKGs before patients start this, and then usually I think 2 weeks after. Also has the risk for peripheral arterial occlusive disease. And then I also think of metabolic type side effects like high triglycerides and pancreatitis. Moving on to bosutinib, which also has a fluid retention side effect and a warning for hepatic toxicity, as well as some GI toxicity with diarrhea. If you kind of look at it just from like the prescribing or the percentages, I feel like a lot of times bosutinib kind of looks the best on paper, but I'll admit I'm pretty skeptical of that. I think it's the newest second-gen TKI. We tend to use dasatinib or nilotinib preferably in front of bosutinib. And I have in our patients who have used it second or third line, I still haven't had great experience with it. So I'm kind of curious to see how that plays out over time as we develop more years with that medication as available to us. And then ponatinib, which is our third gen and really only reserved for certain of the sick patients. does have it's really a challenge anytime we have a patient starting ponatinib to figure out that appropriate counseling level. It has a warning for death and ischemic reactions and vascular occlusion. So definitely not a medication that should be taken lightly. And by the time they're getting to ponatinib, they've probably already had their challenges with. And then moving on to the adherence piece, and this is one of the things that I think is really cool about these agents, is that we always assume our cancer agents adherence is important, and we hope that our patients consider their chemotherapy important enough that they take it on the schedule as intended. But here we have some great data about how important that adherence really is. And so it is one of the most important factor contributing to cytogenetic relapse and imatinib failure. Looking at outcomes from the Adagio study, it is associated with a poorer response to imatinib. Patients with a suboptimal response had higher percentages of imatinib not taken. And then the cutoff rate they found in that study was about 85%, which equates to around 4 missed doses per month for a once-a-day drug. And that led to a 27% chance of losing cytogenetic response at 2 years, compared with 1.5% who had an adherence rate greater than 85%. And then also, so on start of it therapy, or especially if patients are having challenges or rising BCR-ABLs, it's always worth we should be investigating adherence. But it's also good to, I like these associations with adherence, younger patient age, but also toxicity and copays. So just because patients aren't taking their drug as we would like them to be, doesn't mean they don't necessarily have reasons. And so assessing and managing those side effects can improve our adherence as well. And that brings us to the new kid on the block, asciminib, which was just approved in the past year or so. And this is a STAMP inhibitor. And so the excitement with this is that it binds a different spot on the BCR-ABL protein than all the other approved therapies. So this binds the myristoyl pocket, which results in allosteric inhibition of the protein activation. All the other currently approved sites are competitive inhibitors actually in that ATP binding site. So this is licensed both in chronic phase for people who had 2 or more TKIs, as well as patients with a T315I mutation. So it does give us an alternative to ponatinib for patients who have that mutation, which is good. The dosing on these are both kind of interesting. This and zanubrutinib are the first 2 agents that I had ever seen have dual approvals for their daily dosing regimen, where you could do either 80 milligrams daily or 40 milligrams twice a day. I'm still working on developing a schema for which one of those is preferred. So far in therapy, we've been giving this to patients who haven't had great tolerance so far, and so docs have been opting for the twice-a-day regimen. But I think you could make an argument that maybe taking an 80 milligrams at bedtime might give patients the potential to sleep off those side effects and could go better for people. But so far, we've been doing more of the 40 milligram dosing. And then for patients with that mutation, the dose is 5-fold higher at 200 milligrams twice a day. And one challenge with this is that there isn't an alternative pricing or larger tablet size available. So patients need to use 5 of the 40 milligram tablets twice a day, which comes in at over $100K per month for the cash price. On the one patient we had who was on this dosing, it got approved without a second look, but I suspect her insurance is regretting that decision, and I don't think that's going to last forever. I'm hoping the manufacturer will come out with a 200 milligram tablet that's priced comparatively, which is what we typically see in this type of setting, that they have yet. So I expect that to be an access challenge for those patients. This is an empty stomach drug, which once again, twice a day dosing on empty stomach for patients who have already failed 2 TKIs. That could be a challenge for some people. And then similar to many of our other agents, it's a 3A4 substrate, weak inhibitor, so not too likely to cause other interactions, but it is something to be aware of. I did want to dive a little bit more into the adverse effect profile for this, since it is one of the newer agents to the market. On the left side, you can see the chronic phase trial in comparison with bosutinib. And really, I emphasize the grade 3-4 side effects here. And to me, it seems pretty similar tolerance rates, some more musculoskeletal pain and headaches, some nausea, and then some upper respiratory tract infections. And then a little bit more on that thrombocytopenia side. One of the first patients we treated on this had thrombocytopenia with all other TKIs. And so, not surprisingly, whenever he started this, he did have dose-limiting thrombocytopenia again. And so, not a successful agent for him, and he's since moved on to interferon. So, as exciting as asciminib is with that different mechanism of action, some of those same dose-limiting side effects are still retained. And then I was also interested to see, whenever you're using 5-fold the dose, how much more severe those side effects are. And this was a single arm trial, so no comparison, just all grade or grade 3-4 toxicities. And I was pretty pleased by this. I thought this still looked pretty similar to what we would expect based on the comparative trial with bosutinib or other TKIs. So musculoskeletal pain, fatigue, and diarrhea are still pretty common, but with low overall grade 3-4 rates. The hemorrhage was called out, which I didn't notice on the other trials, so I guess that's something to be aware of. And then the cytopenias and the triglycerides. So from a clinical trial standpoint, I think this looks to have similar tolerance to our other agents. In practice, we've been using it on a lot of patients who are serially refractory or unable to tolerate other TKIs. And so we haven't been especially successful with it. I think we're starting about our 4th patient in clinic on this this week. So I'm kind of hopeful that he might have a better time with it than some of these other patients had, but still with a unique mechanism of action, it is something that's exciting to have available. That leads us to our assessment question. We have a 27-year-old male patient started on nilotinib, his first-line therapy for CML, noted to have a suboptimal response, and which of the following might contribute to his suboptimal response? If you could please just put your answers in the chat. Is it A, concomitant carbamazepine use, B, lansoprazole as needed for heartburn, C, occasionally missing evening doses, D, taking with food, or E, all of the above? Sorry, Mike, I don't actually have the chat up. If you could help me out.
Everyone's coming in strong with answer E.
Okay, great. I agree. Glad to hear it. So, and just to dive into that a little further, carbamazepine is one of our induction or CYP3A4 inducer anti-epileptics. Lansoprazole is a PPI, which is contraindicated across the board with our second-gen CML TKIs. Missing evening doses is something we would have to investigate further, as we should be targeting as much adherence as we possibly can, and more than 4 missed doses per month could potentially affect the success rate of the medication. And then nilotinib is, along with asciminib, are the two that are on an empty stomach. So that brings us on to our JAK inhibitors then, with ruxolitinib, fedratinib, and pacritinib, mainly in myeloproliferative neoplasms. We'll start off with ruxolitinib is the first class in this agent, which is nonspecific, so it hits both Janus-associated kinases 1 and 2. And this pathway is thought to have cytokine expression important in hematopoiesis and immune function. So we use it in both myelofibrosis, as well as I see it a lot on the steroid or on the graft versus host disease side. Also a CYP3A4 metabolite. One thing is this does require renal adjustments for creatinine clearances less than 60, which I'd say is a lot of the patients who are seeing these medications. And so I think that's an easy adjustment to really miss or forget about. You can see your approved indications on the right here with fibrosis, myelofibrosis, where it's dosed based on that platelet count, as well as polycythemia vera following hydria. And then, like I said, I use it a lot in the steroid refractory graft versus host disease space, Excited to now have both acute and chronic approved. For acute, the dosing's a little debatable. The phase 2 trial did the 5 BID and then ramped up. The phase 3 acute trial just started patients at 10 BID, so we'll do a bit of both. But I'd say just so long as their counts look okay, I'm okay with starting at the higher dose because there is evidence to support it. But you might see their practice and the FDA labeling has the lower dose to start. And then for chronic GVHD, we're just able to start at the 10 BID. Failure of 1 or 2 previous therapies, so presumably one of those should be steroids, and then we tend to use it second line after steroids. Looking at fedratinib and pacritinib, which were approved over the past 3 years. Pacritinib just in the past year, fedratinib about 3 years ago or so, maybe a little less. These are both JAK2 selective agents approved for use in myelofibrosis. One big difference, whereas fedratinib has a category 1 recommendation for patients with intermediate high-risk myelofibrosis initiating therapy, pacritinib is limited to, the approval is limited to platelets below 50. And so we have had insurance challenges on getting this approved for patients who don't meet that threshold. You can see the dosing there, both hepatic metabolism via 3A4, so nothing too surprising. Big call out from a warning standpoint is the Wernicke's encephalopathy for fedratinib. So this delayed its coming to market for about 5 years. Does seem to have something to do with the medication metabolism that can actually lead to the precipitation of that adverse effect. And so these are patients that we need to be checking and thiamine levels and repleting prior to initiation. And they can be really challenging to get up sometimes. We had a patient who was receiving IV therapy 3 times a week and still had trouble getting to that therapeutic level. So it's a little bit it can be a challenge to manage if you see that. Major adverse cardiovascular events are a side effect for both agents. And then hemorrhage does seem to be high with pacritinib. Of course, that could have something to do with using it in platelets below 50. And then QT prolongation is notable, so EKG is required with pacritinib as well. So I wanted to bring all the side effects together to kind of compare them. And so big call outs here, as you can see, bone marrow suppression is really what I think of as the dose limiting side effect for ruxolitinib, with anemia being the biggest one, followed by thrombocytopenia. And then as you move into your second gen agents, generally there's a downward trend again. So fedratinib, especially with the early approval, we were using this in patients who were intolerant to ruxolitinib due to anemia. Since then, it's gotten a larger ACCN sign off, but I'm still seeing it second line after ruxolitinib. I think just because the bulk of that data that we have available for ruxolitinib. Pacritinib, it has the 32% seen there for the thrombocytopenia. I'd say that's probably a red herring because, once again, this is an agent that was really studied in patients who had low platelets to start with. So really, that would be our preferred agent in the setting of thrombocytopenia. Other things to call out, ruxolitinib, my experience is patients don't have a lot of side effects with it from a diarrhea, nausea standpoint, but you can see the reported numbers for fedratinib and pacritinib are quite high. Not something that I've encountered too much yet, but definitely something that I want to keep an eye on going forward. And then weight gain is something I've recently started calling out with ruxolitinib. This does appear to be fat driven, so not fluid related. And we have had patients put on over 20 pounds really of fat over 2 to 3 months on the drug. So it has required switching to alternative agents. There's a couple early publications on lab studies, and it does seem to be a JAK side effect. So it can be something that's difficult to manage, not that well reported, so something to keep an eye on. Brings us to our FLT3 inhibitors, midostaurin and gilteritinib in the AML space. I also just mentioned here quizartinib because we're expecting an FDA approval soon. And then sorafenib, which is more in the hepatocellular carcinoma space and was covered elsewhere, but can be used for its FLT3 capabilities. So FLT3 is FMS like tyrosine kinase receptor 3. Serves a role in hematopoietic survival and proliferation. two different types of mutations. So either ITD, internal tandem duplication, or TKD, tyrosine kinase domain. These have different kind of characteristics of AML, whether it's an ITD type or a TKD subtype. And then also for our different inhibitors, type 1 inhibitors inhibit both types versus type 2 inhibitors, sorafenib, quizartinib, are only effective against the ITD subtype. Like many other oral chemo agents, we have our first gen, which are more non-specific, like midostaurin, and then second gen with gilteritinib are more potent and selective, and so hopefully better tolerance and potentially more efficacy, which we're actively investigating. So here's your comparison chart for these. Midostaurin is only indicated in frontline therapy and consolidation in combination with 7+3 and HiDAC. Gilteritinib in AML is only licensed in the relapse or refractory space. Gilteritinib is able to be given continuously versus midostaurin is really just 2 weeks of therapy. Both are hepatic metabolism via 3A4. Nausea is quite potent with midostaurin. If you've ever smelled it, it smells like a skunk. There's like a really strong sulfur component to it. So it is a medication that we pre-med with antiemetics. Gilteritinib seems to go better for patients, although things to call out there is still transaminitis, nausea, diarrhea. And then we've had a couple of patients admitted for pancreatitis while on gilteritinib. Midostaurin has a pneumonitis warning, which I haven't encountered much, but it is pretty well documented in the package insert, and then both are QT prolongers. And then the other thing to call out with the 3A4 metabolism in AML, these are patients who have a mortality benefit from posaconazole. So that is an interaction that we're going to have to manage pretty commonly, and whether that's using micafungin for patients while they're admitted for their 7+3, or something like Cresemba for patients on gilteritinib. If someone's on that posaconazole, we do tend to dose reduce the gilteritinib, but there's the recommendations aren't in practice across the country isn't exactly clear on how best to manage that. And our IDH inhibitors, which is isocitrate dehydrogenase. This results, or the mutant form of this results in inability of cells to differentiate and accumulation of leukemic blasts. Two isoforms, IDH1, which occurs in the cytoplasm, versus IDH2, which occurs in the mitochondria. Both result in increased R2 hydroxyglutarate formation. And so our two agents here, ivosidenib is our IDH1 inhibitor versus enasidenib is our IDH2 inhibitor. You can see there's a broader approval for ivosidenib with either newly diagnosed or relapse refractory AML, versus enasidenib is only approved in relapse or refractory patients. Both have hepatic metabolism. Side effects to call out. The big class one is differentiation syndrome, which we'll talk a little bit more on the next slide. The elevated bilirubin from enasidenib is also something that has specific modifications and can occur commonly, or dose modifications if that does occur. And then both are QT prolongers as well. Whenever these first came on the market, I think everyone thought they were pretty similar, but as they've come along, I think we're starting to notice more and more differences between the two agents. So differentiation syndrome occurs through rapid proliferation and differentiation of myeloid cells, and side effects can commonly include dyspnea, pulmonary infiltrates, pleural effusion, renal impairment, fever, as well as weight gain. One call out that's a contrast with the agent we're going to talk about next is there's more of a delayed onset with these, so 10 days to 5 months. So median occurs 1 to 2 months out from therapy. And then treatment is going to be with steroids until symptom resolution. Final agent for the day is the retinoic acid derivative, tretinoin, otherwise known as all-trans retinoic acid, thinking back to your organic chemistry courses, or ATRA, which is the chemical name for it. And so this is used in acute promyelocytic leukemia as a differentiating agent. So that mechanism gives a similar result to what we see with the IDH inhibitors, but some big differences here. Our dosing is 22.5 milligrams per meter squared twice a day. It only comes in 10 milligram caps. So this is a pretty high pill burden for patients, about 5 caps twice a day for most people. It's continuous with the first cycle, and then that duration decreases with subsequent cycles. The caps are small, but it is an expensive med, so there can be some challenges there. Hepatic non-3A4 metabolism and no renal or hepatic modifications needed. Our differentiation syndrome for this agent can occur within hours of the first dose, so more in that first week, first couple of days of therapy that we're looking at. We will use prevention for our APML patients with prednisone. However, if they progress to actual differentiation syndrome, the treatment is similar with Dex-10. The metabolic side effects with this can be quite potent with triglycerides or cholesterol. Up to 60% of patients require pharmacologic therapy, looking at trying to prevent pancreatitis whenever you get those triglycerides over 1,000. LFT abnormalities can occur. It's something that's generally reported as a well-tolerated agent, but we've had a lot of patients who've had strange side effects or metabolic side effects, and it can be challenging to manage because there aren't any backup options. This is really our go-to. So that's a lot of space we covered in the myeloid realm, and then I'm going to hand it off to Maggie to cover the lymphoid diseases. And then, Mike, do you want me to hang on in case there's any questions at the end?
Yeah, if you have time.
Yeah, that works.
Yeah, thanks, Cam. We'll get Maggie's slides up now, and as a reminder for everyone, we'll have videos available of the content. A lot of stuff here today. This talk may go a couple minutes late, but we'll try to get done on time here. Thanks, everyone. Looks good, Maggie.
All right, without further ado then, good morning, everyone. Thanks for having me. My name is Maggie Schenkat. I'm a clinic pharmacist, and I am primarily in the hematology and gynonc space. So I'm going to pick up where Cam left off here with the hematology oral chemotherapy agents, part 2. Cam read off the objectives, same go for my presentation here. This is our roadmap for the second part. We'll start off by talking about the immunomodulatory agents, or the IMiDs, followed by BTK inhibitors, PI3K inhibitors, the BCL2 inhibitor venetoclax, and then we'll end with our nuclear export inhibitor, selinexor. So we'll jump right into the immunomodulatory agents, which include lenalidomide, pomalidomide, and thalidomide. All right, so we can't talk about the IMiD class without first touching on a bit of the history of the thalidomide tragedy and when it first hit the market. So this history is really important. It plays a role in the education and monitoring that we do today via the REMS program for all IMiDs, and I'll touch on that shortly. So thalidomide was first marketed in Germany in the late 1950s as a sleep aid. It was shortly thereafter used in the treatment of morning sickness in pregnant women. Within a few years of its widespread use in Europe, Australia, and Japan, around 10,000 babies were born with a condition called phocomelia, which is a condition of shortened, absent, or flipperto-like limbs. It wasn't until 1962 that a physician associated the drug with these birth defects, and then it was banned in many countries thereafter. So this tragedy was actually avoided in the U.S., in large part because of the FDA inspector at the time, Frances Kelly. She held up the approval of thalidomide in the US prior to the known association of these birth defects because of the lack of data in this pregnant population. She was actually mostly concerned about the side effect of peripheral neuropathy in pregnant patients at the time. But following this coming to light of these birth defects associated with this medication, President Kennedy actually awarded her with the Gold Medal Award for Distinguished Civilian Service. And that was really for holding her ground despite pressure and approving this in the USA before we really had data to show its safety. So this thalidomide tragedy also led to the Kefauver-Harris Drug Amendment Act, which required medications to be proven safe and effective prior to marketing. And then it was later in the 90s that thalidomide was approved in the multiple myeloma and actually leprosy treatment settings. All right, so next we'll talk about the REMS program. So all three IMiDs have similar REMS programs. The goal is really to prevent risk of embryo fetal exposure to this class of medications, and then to inform prescribers, patients, and pharmacists on the serious risks and safe use conditions. Only certified prescribers and pharmacies can write for and dispense IMiD therapies. So prescribers, patients, and pharmacies all have their portions of this REMS program that they have to complete with every single fill of the medication. So prescribers, or oftentimes this is going to be your team nurse helping with this, we have to get an authorization number for every single prescription. You have to list the auth number and patient risk category right on the prescription. We'll have to verify a negative pregnancy test for all females of reproductive potential. These prescriptions can only be written for a 28-day supply at a time, and they cannot have any refills on them. So new prescription with every dispense. Patients have to complete confidential surveys prior to filling the medication, and that's done either online or via phone. And then reproductive females have to use 2 effective methods of birth control. And then lastly, pharmacies have to essentially verify and confirm that auth number prior to each dispensing. And then they'll have to complete education, counseling, and a checklist for every single dispense. As far as the mechanism of action of these medications go, we know it's multimodal, but we don't completely understand how they work in the cancerous settings. So we know there's some direct cytotoxicity and apoptosis on cancer cells. They inhibit interleukin-6 release and decrease myeloma cell adhesion. There's decreased angiogenesis, and then there is enhanced T cell cytokine production and natural killer cell mediated cytotoxicity as well. So while structurally all of the IMiDs are very similar to one another, clinically there are some very key differences in how we use them, as well as some of the pharmacokinetic and pharmacodynamic effects. So you'll see thalidomide has 2 major indications, multiple myeloma and leprosy. It's dosed at a range between 50 and 200 milligrams, and this is given continuously daily. As far as metabolism goes, it undergoes hydrolysis, so it's a non-renal and non-hepatic form of clearance. Lenalidomide has the most indications, so multiple myeloma, it's indicated in several different lymphomas. And then myelodysplastic syndrome, primarily are patients with deletion 5q. Dosing ranges from 5 to 25 milligrams, and this is most commonly given on a 3 weeks on, 1 week off schedule. This is mostly because of the myelosuppression associated with it, which we'll talk about. It undergoes renal elimination, and we do have dose reductions that are required for creatinine clearance less than 60, which, as you're probably guessing, a large portion of our patients, especially in the multiple myeloma setting. And then lastly, pomalidomide is indicated in multiple myeloma and Kaposi sarcoma. Dosing is 1 to 4 milligrams. Again, this one's dosed on the 3 weeks on, 1 week off dosing schedule commonly. And then this one undergoes hepatic metabolism via the CYP1A2 and 3A4 systems. So again, we should be thinking about drug interactions anytime something is hepatically cleared through the CYP system. IMiDs have some class adverse effects and then some agent-specific adverse effects that we'll discuss now. So embryo-fetal toxicity is a class adverse effect, and that's in large part overseen by the REMS program. We worry about DVT, MI, and stroke in all of these medications. So thromboprophylaxis is recommended in all patients. We primarily use a full-strength aspirin daily. Rash is a class effect, and then infection as well. And then there are some agent-specific side effects. So thalidomide, like I discussed before, has some dose-limiting neuropathy and then significant fatigue associated with it. Myelosuppression is the dose-limiting toxicity for both lenalidomide and pomalidomide. Lenalidomide is both renally eliminated and can be nephrotoxic in certain circumstances, so we have to use with caution in these patients. And then second primary malignancies is most commonly noted with lenalidomide. Next, we'll talk about the Bruton's tyrosine kinase inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. So Bruton's tyrosine kinase, or BTK, is integral to the B cell receptor signaling system. Constitutively active BCR signaling is a common feature of B-cell malignancies. So if we can inhibit BTK, we can essentially inhibit BCR signaling, leading to cell death and inhibition of cell migration and proliferation. So you'll see on the right-hand side, this table here, all of the BTK agents available right now are covalent and irreversible binders of BTK. The most selective is acalabrutinib. You'll see ibrutinib is the least selective of BTK and has several off-target receptor effects. So EGFR, ITK, TEC, BMX, HER2, and JAK3. And a lot of these off-target receptor effects lead into some of the side effects that we'll see. As far as indication goes, ibrutinib's been around the longest and has the most indications. So it's indicated in CLL, in second-line use in mantle cell lymphoma and marginal zone lymphoma. You can use it in Waldenstrom macroglobulinemia, and then as an agent in chronic graft versus host disease in the refractory setting. Acalabrutinib is FDA approved in CLL and then second-line mantle cell lymphoma. And then zanubrutinib is approved in the lymphoma setting and the macroglobulinemia setting. All right, this next slide here highlights some of the dosing considerations with the different agents. You'll see as an overall class effect that none of these agents require renal adjustments, which is nice. Downside is all of them undergo hepatic metabolism via the CYP3A4 system. So again, we should be thinking heavily that these are going to rely and probably cause a lot of drug interactions that we'll have to be mindful of. So as far as individual agents go, ibrutinib is dosed depending on the indication. So it ranges from 420 to 560 milligrams daily. The higher dose of 560 milligrams is indicated in the lymphoma setting. You do need to dose adjust in mild hepatic impairment, and there's no drug interactions with acid suppression. Acalabrutinib is our one agent that is dosed twice daily. So again, keeping that in mind from an adherence perspective, it's harder to remember to take 2 doses a day than 1. You do have to avoid it in severe hepatic impairment. And this is the only agent that does have drug interactions with stomach acid suppression of these agents. So it's totally contraindicated when using with a PPI. You can use it with H2RAs and antacids, but they do have to be dosed with certain timing around administration of acalabrutinib. And then zanubrutinib is that interesting 2 different dosing schemas that are allowed, either 160 milligrams twice daily or 300 milligrams once daily. You do need to adjust it with severe hepatic impairment. And again, no stomach acid suppression interactions here. As far as toxicities go, as far as class effects go, the major ones that I tend to think of are atrial fibrillation, bleeding, grade 3 or higher, diarrhea, rash, and headache. And you'll see that in general, ibrutinib has higher rates of toxicity. The major exception being acalabrutinib is overall, with it being more selective, a little better tolerated with these, but there is more headache seen with it. So ibrutinib is thought to have these additional atrial fibrillation and bleeding impacts due to the non-selective inhibition of the TEC kinases. And then the diarrhea and rash is thought to be higher because of its off-target EGFR inhibition. So we actually do have a phase 3 randomized controlled trial. It was a non-inferiority trial looking at acalabrutinib versus ibrutinib. It was the Elevate-RR study. And this is great because it allows us to actually directly compare both the efficacy and really the toxicity profile between these 2 agents within the same trial. So I've highlighted some of the big ones here in this orange table. You see that overall major bleeding is higher in the ibrutinib group. Grade 3 or higher atrial fibrillation is a little higher in the acalabrutinib group, but any grade atrial fibrillation is statistically more common with ibrutinib. We see again that diarrhea especially the higher grade is more common in ibrutinib. And then again, headache, which is a little more commonly seen with acalabrutinib, did hold true in this trial, so higher rates of headache here. The last thing I wanted to touch on with BTK inhibitors is lymphocytosis, as this is a class effect. This is commonly referred to as redistribution lymphocytosis, and it's important to know that this is not necessarily disease progression in these patients. It's a transient ALC increase, and it's a result of chemokine receptor inhibition. It causes trafficking of the CLL cells from the lymph node into the peripheral blood, resulting in this lymphocytosis. So this is not associated with relapse or toxicity. The onset is typically pretty immediate upon initiation of therapy, and the duration is really highly variable between patients. So it can last anywhere from days to weeks. Next, we'll talk about our BCL2 inhibitor, venetoclax, and that's B-cell lymphoma 2. So venetoclax works by inhibiting BCL2, which is an anti-apoptotic protein leading to cell death. Most common indications and our FDA-approved indications are CLL. It can be used alone or in conjunction with an anti-CD20 antibody. And then in AML, it's used in patients who are unable to tolerate intensive chemotherapy, and it's used in conjunction mostly with azacitidine and decitabine, but there is approval to use it with low-dose cytarabine as well. You may see it used in off-label indications as well. So multiple myeloma, specifically patients with translocation 11-14, the relapsed refractory setting, and then mantle cell lymphoma, again, relapsed refractory setting with or without ibrutinib. All right, so these two dosing schedules are what you'll see in the package insert for both CLL and AML therapy. So CLL, we have a high concern for TLS with these patients. So they require a slow ramp up over the course of 5 weeks, and the doses are listed here. AML, you will see a ramp up in the package insert, mostly a 3-day ramp up period, but we often just initiate it right at the goal dose without ramp up due to the overall low TLS risk in this patient population. All doses of venetoclax should be administered with food. And then this medication is highly dependent on 3A4 metabolism, so it's very susceptible to drug interactions. This is mostly going to be of concern in our AML patients who are also going to be needing antifungal therapy, usually an agent like posaconazole, and this goal dose is adjusted based on the antifungal therapy that the patient is on. So as far as adverse effects here, it does vary somewhat based on the indication. Oh no. Just a sec here. Did you guys lose my slides?
Yeah, they fell off.
Shoot, give me just a sec. All right, sorry about that. So as far as adverse effects go, they do vary somewhat based on the indication. So myelosuppression is a big one. Neutropenia and thrombocytopenia are most noted. Febrile neutropenia rates are a lot higher in our AML patients. Diarrhea is the most common GI side effect. And then hyperuricemia is most commonly, again, seen in our CLL patients, again, as a part of that overall TLS concern, and not really as much of a concern in our AML patients. So as far as TLS prevention and monitoring goes, again, our chief concern is our CLL patients. It requires that slow dose ramp up that I had pictured on previous slides. All patients need to receive allopurinol about 72 hours prior to venetoclax initiation, and rasburicase can be considered for our high-risk patients or those with baseline elevated uric acid. Hydration is crucial in these patients, so education around the need for oral hydration, plus or minus some IV fluids, which can be given in the clinic setting or even if in the hospital setting if we're doing a hospital initiation. And then patients are risk stratified based on their tumor burden and comorbidities like renal dysfunction. And this kind of leads to how we feel like we need to monitor these patients. So our low to medium TLS risk patients are going to be monitored and initiated in the outpatient setting. They do still require extensive lab monitoring though. So we'll get labs at baseline, 6 to 8 hours post-dose, and then 24 hours post-dose for the first 2 weekly ramp-up doses, and then pre-dose for the remaining escalations. For our high-risk patients, those are the patients that may be admitted to the hospital for monitoring while we're initiating those first 2 doses. So this requires labs every 4 hours for the first 12 hours, and then again 24 hours post-dose. And then once you get to the 100 milligram and subsequent dose initiations, they still need that frequent monitoring in clinic. So labs at baseline, 6 to 8 hours post-dose, and then 24 hours post-dose. Next, we'll jump into our PI3K inhibitors, idelalisib, copanlisib, and duvelisib. So the PI3K pathway is an important pathway for cell growth, apoptosis, cell metabolism and survival, and other crucial cell functions. There are 3 classes of the PI3K families, each having at least one subclass with further isoforms. The PI3K class of interest in drug targeting is class 1, which you'll see on this slide here. So PI3K inhibitors can be pan inhibitors, which inhibit all isoforms, isoform specific, or dual PI3K and mTOR inhibitors. And the toxicity and efficacy really kind of depend on the isoform specificity. So you'll see here our alpha isoform. Alpha and beta specifically are expressed on multiple tissues, and the alpha isoform has a role in insulin signaling. So some side effects that we see with these PI3K alpha inhibitors include hyperglycemia being one of them, and then rash. Our delta isoforms are preferentially expressed on leukocytes. So myelosuppression is a common toxicity of these agents. And then we see a lot of GI toxicities and transaminitis as well. And then our pan inhibitors have dose-dependent side effects and can include fatigue, diarrhea, rash, and hyperglycemia. So these are our 4 PI3K inhibitors on the market right now. You'll see idelalisib is specifically indicated in the relapsed CLL setting. It's an oral formulation and dosed twice daily. Copanlisib is our only IV PI3K inhibitor available right now. It's dosed weekly, and it's specifically indicated in the relapsed follicular lymphoma setting. Duvelisib is another oral agent that's dosed twice daily in a relapsed CLL setting. And then alpelisib is used in our solid tumor space. It's indicated in the advanced breast cancer setting, specifically in our PI3K mutated breast cancers. And that's an oral formulation dosed once daily. I did just want to call attention to some recent changes that were made to this class of medications and some of the labeling of the agents. So both duvelisib and idelalisib used to be indicated in the follicular lymphoma space, idelalisib in the SLL space as well. This labeling was recently voluntarily pulled by the manufacturers. These 2 agents in this setting were approved via the accelerated approval pathway. And as a contingent part of that approval, they had to essentially do more confirmatory studies. Both of the manufacturers said, we don't want to do those confirmatory studies. Copanlisib is already indicated in this setting and withdrew that approval. And then umbralisib had a removal from the market. It was approved in the follicular lymphoma and marginal zone lymphoma space, and it had been pulled from the market entirely just based on updated trial findings that showed a possible increased risk of death in these patients. So I'm going to use adalimumab as kind of my medication to discuss adverse effects. Overall, this medication class is quite toxic and hard to tolerate. So you'll see that fatal and serious hepatotoxicity occurred in up to 16% of patients who were taking adalimumab. Grade 3 or higher diarrhea and colitis occurred in 20% of patients. This diarrhea colitis picture isn't oftentimes responsive to normal anti-motility agents like loperamide, and a lot of these patients end up needing corticosteroids. Fatal or serious infections occurred in 48% of patients. So things like PJP pneumonia occurred, so we require PJP prophylaxis when using this medication. CMV reactivation is a possibility, so monitoring in our seropositive patients is important. Grade 3 to 4 neutropenia was seen in 58% of patients. And then we also have to look out for pneumonitis and serious cutaneous reactions. The last drug that we'll cover today is our nuclear export inhibitor, selinexor. So selinexor specifically inhibits XPO1. XPO1 is a nuclear transport protein that's overexpressed in cancer cells. Its major responsibility is for transporting growth regulators, tumor suppressor proteins, and oncoprotein mRNA out of the nucleus and into the cytoplasm. So when we have selinexor then inhibiting XPO1, it can't carry these proteins out of the nucleus. This leads to accumulation and eventual apoptosis of cells. So selinexor is indicated in 2 settings right now: the relapse refractory diffuse large B-cell lymphoma space. It's dosed as 60 milligrams twice weekly, and that's taken on days 1 and 3 of each week, and it's monotherapy in that setting. Multiple myeloma, it depends on the treatment regimen you're using. So in combination with dexamethasone, it's dosed as 80 milligrams twice weekly on days 1 and 3 each week. And with bortezomib and dexamethasone, it's dosed as 100 milligrams weekly on day 1 of each treatment. Selinexor also has some significant adverse effects that we have to monitor our patients for. I think it's kind of interesting to note that in the studies, over 60% of patients had dose interruptions or adjustments made because of these toxicities. So thrombocytopenia was the leading cause of dose modifications. Neutropenia, we can consider dose modifications, antimicrobials, or potentially GCSF use. It has a lot of GI toxicity associated with it, so nausea, vomiting, weight loss, and diarrhea. In terms of nausea prevention, we do give patients prophylactic scheduled antiemetics. So at least giving them ondansetron or another serotonin antagonist scheduled prior to their first dose of selinexor. And then you can also give oral aprepitant, rolapitant, oral olanzapine as a second agent. This medication can also cause hyponatremia. Neurologic toxicity has been noted, so dizziness, syncope, depressed level of consciousness, vertigo, and many others. So because of this, we educate patients not to drive or operate heavy machinery until they know how the medication is going to affect them. And then lastly, there is a risk of cataracts, and that's new or worsening cataracts. So looking at some of the rates of these common adverse effects, thrombocytopenia, again, you're seeing really high rates of thrombocytopenia and almost 50% of patients having a grade 3 to 4 thrombocytopenia event. Bleeding did occur in about 23% of patients in trials, so do keep that in mind. Again, a big reason for dose adjustments. Neutropenia occurs in about 50% of patients. You'll see that nausea is common even with prophylaxis. Hyponatremia, again, occurring in over 50% of patients. And then about a quarter of patients will experience some degree of the neurologic toxicity. All right, so my last slide here are just some general conclusions on oral chemotherapies and some things to keep in mind. So like Cam had said, use class and mechanism of action to kind of set a baseline for yourself when you're thinking about toxicity and dosing strategies for oral chemos. And then you do also want to be thoughtful about individual drug differences when you're thinking of drug interactions or, again, kind of unique side effect profiles. You have to be very conscious of interacting medications. So some red flag drug and drug classes that I think about would be like warfarin, anti-epileptics, highly effective antiretroviral therapies, azole antifungals, and antiarrhythmics are some that I think of as just red flag drugs for patients starting oral chemos because they're common causes of drug interactions. And then always be double checking if it's okay to use stomach acid suppression with oral chemotherapies until you're getting to know your agents and know which ones it's okay to use it in and which ones it's not. For patients with renal or hepatic dysfunction, check the specific agent for dose modifications. So package inserts with oral chemotherapies will often do a good job of spelling out these requirements. You can check tertiary drug databases, but just always be cautious when you're checking those and making sure you know where that information is coming from. And then lastly, even though these medications are meds that are taken at home, they still do require a lot of monitoring. So just setting that expectations for patients. Yes, this is a medicine you take at home, but we'll still be seeing you back in clinic quite frequently for XYZ monitoring that's associated with that specific drug. So thanks again for your time, and 2 minutes over, but happy to take any questions from anyone.
I have a quick question, and thanks so much, Cam and Maggie, for a great talk. I've seen a couple of patients on dasatinib who have developed pleural effusions. How long after holding the drug does it usually take for the dasatinib to clear their system where we'd be expecting their pleural effusions to resolve? Is it usually like on the order of days or weeks?
I think there's a difference between when the drug clears the system and when the toxicity would resolve. So like without looking at it, I'd expect the half-life for dasatinib is like up to a day, drug out of their system within a week. But I still think you could see the pleural effusion could take longer than that to resolve. Like it's more on the scale of weeks would be what comes to mind for me.
Okay, great. Thank you. That's what I was thinking.